Hello everyone. We will talk about implication of hypertension on anesthesia. Data says that 1/3 of adults coming for non-cardiac surgery come with hypertension as comorbidity, and 2/3 of adults coming for cardiac surgery comes with hypertension as comorbidity. So seeing the data, we can say that hypertension is one of the leading comorbidity which we will face during pre-anesthetic evaluation of our patient coming for any surgery. So as I said, what does data says? That 1/3 of adult coming for non-cardiac surgery have hypertension as comorbidity, and 2/3 of adult coming for cardiac surgery has hypertension as comorbidity, right? In this section, I will talk about everything related to anesthesia implication in a hypertensive patient. We will talk about right from the definition of hypertension, how do we classify hypertension, and we will also know that whether a chronic hypertensive coming for surgery and has an elevated blood pressure, the case should be cancelled or we can go ahead with the case. How much is the risk associated with surgery in a hypertensive patient? What are the factors on which risk depends? What are the important things that we have to see in pre-anesthetic evaluation? What are the important intra-op complications which we may face in these patients and we have to be prepared with? And what is the immediate post-op management which we need to look in these patients? So we will discuss all these things. So let us start our discussion with the definition of hypertension. So definition of hypertension little vary between a different society which has given the definition, the American and the European society. So according to the American Heart Association and American Cardiology Society, the office-based definition of hypertension is if systolic blood pressure is above 130 and diastolic above 80, then they define it as hypertensive patient. And if the self-measurement of blood pressure is above 130 by 80 in home, consistently it is coming more than 130 by 80, then again it comes under definition of hypertension. Then ambulatory blood pressure measurement, daytime ambulatory blood pressure measurement more than equal to 130 by 80, again comes under the definition of hypertension. Nighttime ambulatory blood pressure measurement above 110 by 65 can come under definition of hypertension, and 24-hour ambulatory blood pressure measurement more than 125 by 75 comes under definition of hypertension. European Cardiology Society and let's say European Society of Hypertension, the guideline which they passed in 2018, they defined hypertension more than 140 by 90 blood pressure when measured in clinic, and for self-measurement of blood pressure more than 135 by 85 can be defined as hypertension. For ambulatory setting, ambulatory daytime more than 135 by 85, ambulatory nighttime more than 120 by 70, and 24-hour ambulatory blood pressure measurement more than 130 by 80 comes under definition of hypertension. So little variation is there. We will follow American Heart Association or American Cardiology Society guidelines, right, for definition of hypertension. Okay. Now, apart from this, we need to know exactly what is the normal blood pressure, what is the elevated blood pressure, what is stage 1 hypertension, what is stage 2 hypertension, then what is hypertensive emergency or hypertensive urgency, or what is, let's say, significantly elevated blood pressure. All these are different terms that we need to be aware of. So, normal blood pressure, as we all know, that normal blood pressure is defined as the systolic blood pressure less than 120, diastolic blood pressure less than 80. Okay. Elevated blood pressure, but not coming under the criteria of hypertension, is systolic between 120 to 129 and diastolic less than 80 mm of Hg. Now coming on hypertension definition, above stage 1, stage 2 hypertension. Stage 1, stage 2. Stage 1 hypertension is systolic between 130 to 139 mm of Hg and diastolic between 80 to 89 mm of Hg. Right? And stage 2, systolic at least or equal to at least above 140 mm of Hg and diastolic above 90 mm of Hg. That is stage 2 hypertension. So stage 1, as I said, between 130 to 139 mm of Hg systolic and diastolic between 80 to 89 mm of Hg, right? And stage 2, systolic more than equal to 140 and diastolic more than equal to 90 mm of Hg. Okay. We can have isolated systolic hypertension, isolated diastolic hypertension as well. Now, if how do we give staging in them if we have isolated diastolic or isolated systolic hypertension? So we see which is the primarily, which is what is elevated, and according to that we give the staging to the patient. What do I mean by this is that if there is disparity in the category between systolic and diastolic pressure, the higher value determines the stage. So if systolic is between 130 to 139 but diastolic is above 90, then it comes under stage 2, not in stage 1, right? So whichever is the higher value, that would decide the stage. Now, very important, one more definition. As I said, we can have isolated systolic, isolated diastolic, and we can have mixed systolic and diastolic. Isolated systolic, the blood pressure more than equal to 130 mm of Hg, systolic, but diastolic less than 80 mm of Hg. Isolated diastolic, systolic less than 130 mm of Hg, diastolic more than equal to 80 mm of Hg. And mixed when both are elevated. So more than 130 systolic, more than 80 diastolic comes under mixed systolic and diastolic hypertension. Okay. What is white coat hypertension? That's a very common term which we hear about. Now, white coat hypertension is the elevated blood pressure when measured in clinics, but not, the blood pressure is not elevated when it is measured at home, right? So, white coat hypertension is defined as blood pressure that is consistently elevated in clinics but does not meet the diagnostic criteria for hypertension based on out of office setting. Then masked hypertension is just opposite to white coat hypertension. Masked hypertension is blood pressure is not meeting the diagnostic criteria in clinics, but out of clinic the blood pressure is elevated. So it is defined as blood pressure that is consistently elevated out of office measurement but does not meet the criteria for hypertension based on office reading, right? So masked hypertension. Now, we discussed stage 1, stage 2 hypertension. Now, stage 1, stage 2, stage 1 is between 130 to 39 by your 80 to 89 mm of Hg. Stage 2 is above 1 equal to 140, above equal to 90. But there is a stage which is above stage 2 as well. That is significantly elevated blood pressure, significantly elevated blood pressure. Now, how do we define significantly elevated blood pressure? Significantly elevated blood pressure is systolic blood pressure above 180 mm of Hg, diastolic above 120 mm of Hg with no evidence of any end organ damage, with no acute end organ injury. This is called severe asymptomatic hypertension, right? So, we discussed stage 1, we discussed stage 2. Stage 1 was between 130 to 139, right, and 80 to 89 mm of Hg, systolic and diastolic. Stage 2 was more than equal to 140 by more than equal to 90 mm of Hg. Now, severe symptomatic hypertension is more than equal to 180 by more than equal to 120 mm of Hg with no evidence of any acute organ injury. Now, we have hypertensive emergency, hypertensive emergency, or we call it hypertensive urgency. Now this emergency and urgency, we call it when we have elevated blood pressure with evidence of end organ injury, right? With some evidence of end organ injury, especially for heart and brain. If it's an hypertensive emergency and urgency, definitely we need to give medications for an acute decrease in blood pressure to minimize the end organ injury. But if it is a severe asymptomatic hypertension, then it is more advised to give medications which would gradually decrease the blood pressure. A chronic management is more what is advised rather than acute decrease in blood pressure. Okay. Now these are the important definitions that we need to know about. So when a hypertensive patient with a known hypertension or patient with an elevated blood pressure comes in the pre-anesthetic checkup for some surgery, what are the important considerations that we have to keep in mind? So we'll talk about the pre-anesthetic checkup for these patients. As we have previously also discussed, there are two important things we need to see in pre-anesthetic checkup. We need to decide in pre-anesthetic checkup. Number one, we need to see that if a patient has a comorbidity, and if patient has comorbidity, what are the risks associated with surgery? So we have to calculate the risk, and we need to optimize the comorbidity of the patient to the fullest. So risk calculation and optimization are two very important things that we need to keep in mind. So if someone is chronic hypertensive, these patients, they have many other comorbidity related to cardiac and neuro associated in them. So we need to look for those co-presence of those comorbidity in the patient. So chronic hypertension is associated with long-term morbidity, because of association of many other diseases like your ischemic heart disease, like heart failure associated with them, cerebral vascular disease, and renal insufficiency. Okay, so these are the important co-diseases which may be associated in hypertensive patient. Now, one very important thing that we need to know when we are evaluating these patients, that the risk in these patients depends on the severity of hypertension and the duration of hypertension in these patients, or duration of hypertension in these patients. So the level of risk is dependent on severity of hypertension and duration of hypertension, right? So we need to take the history of both. We need to see for how long the hypertension is associated in these patients and which stage the hypertension comes in these patients, severity and duration. Now, there are a number of time question that would postponement of surgery, if a chronic hypertensive comes to the pre-anesthetic checkup and they have an elevated blood pressure, would postponement of surgery would reduce the risk in these patients? Should we need to postpone the surgery? We need to optimize the patient to the fullest and then take the patient for surgery once the blood pressure comes within the normal criteria? Actually, no. What I am trying to say that actually no, I shouldn't say, it's unclear actually. So it is unclear whether postponing the surgery to achieve blood pressure control would lead to reduced cardiac risk. cardiac risk in these patients. So it is unclear that we should postpone if they have an elevated blood pressure. Now, what does let's say hypertension comes under what criteria? The low risk, mild risk, or moderate risk according to the American Heart Association. We need to know. So, American College of Cardiology and American Heart Association guideline lists uncontrolled hypertension, the hypertension which is not controlled, right, as a minor risk factor for perioperative cardiovascular event. So they say it is a minor risk factor for perioperative cardiovascular events. So stating this, since it is a minor risk factor, right, we need to know few important things during its management, right, taking these patients for surgery during their management, and we should go ahead with surgery rather than postponement of the surgery for the numerical control of the blood pressure. They come under minor risk. Okay, so there are few studies which have shown that in severe hypertensive, one very important landmark study which showed in severe hypertensive, now patient with systolic blood pressure more than 210 and diastolic blood pressure more than 105, if patient has a severe hypertension, then the risk of exaggerated hypertension and exaggerated hypotension is more in them. Now, with anesthetic agent given, exaggerated hypotension is seen in them, and with noxious stimuli and level of pain not adequate, exaggerated hypertension seen in them. So what I'm trying to say, that these patients had risk of exaggerated hypotensive response, and exaggerated hypertensive response, right, to the noxious stimuli. So the study shows that severe hypertension, this was what was seen. And the same study show that patient had well-controlled hypertension, the response was normal like any other patient. So response was normal or similar to non-hypertensive, Okay, so in patient with severe hypertension without evidence of end organ failure, not in hypertensive emergency or urgency, the hypotensive and hypertensive response is exaggerated, and we need to take care of this. But in patient with well-controlled hypertension, the response is similar like any other normal patient, right? Like any other normal patient. Now, stage 1 and stage 2 hypertension. The lot of studies have shown that stage 1 and stage 2 hypertension, right? Patient with, that is, systolic blood pressure and patient with less marked, stage 1, stage 2, less than 180 mm of Hg systolic and less than 110 mm of Hg diastolic. All right, they do not appear to be at increased operative risk, right? So in them, surgeries should not be delayed just on the ground of hypertension. So in them, surgery should not be delayed, right? Just on the ground of hypertension. So should not be delayed. Okay. Just we need to practice cautions interop in blood pressure monitoring and management. So we just need a caution, but surgery should not be delayed. If hypertension is associated with heart failure or kidney function impairment or probability of adverse cardiac event increases. So hypertension associated with heart failure and kidney function impairment, is associated with has a probability of adverse cardiac outcome probability, right? So they have an adverse cardiac outcome probability. Now, I talked about systolic hypertension and diastolic hypertension. Systolic hypertension has not shown to increase any operative risk in these patients compared to diastolic hypertension. Diastolic hypertension has more implication. So, compared with isolated diastolic hypertension, systolic hypertension does not increase operating risk. Okay. Now, apart from this, you may get patients with secondary hypertension. Say hypertension due to some associated conditions, some mass, some tumors, etc. In these patients also, they should ideally undergo a diagnostic evaluation prior to elective surgery. They also have shown not to have any elevated risk associated with them. We can go ahead with surgery with an exception if pheochromocytoma is causing the hypertension, secondary hypertension. So, secondary hypertension. Now, patient with suspected secondary hypertension should ideally undergo diagnostic evaluation. And they also do not show any increased risk. Are not at increased risk, right? As compared to the primary hypertension. Only we need to see that their electrolyte, their kidney function, etc. is normal. So they should ideally undergo diagnostic evaluation. They are not at increased risk. Only if there is association of pheochromocytoma, right, then definitely they are at increased risk, and then we have to take a decision whether to go ahead with the surgery depending upon the urgency of the current surgery, and let's say rather than managing the patient for pheochromocytoma and getting the patient operated for the adrenal mass tumor, right? So which surgery we have to undertake first, the proper decision has to be taken about after proper evaluation and evaluating the type of surgery the patient has come for. Okay, so in, let's say, summary, whatever I have said, let me summarize it. So what does the consensus says? So a lot of things I talked about, that surgery should not be cancelled. The American College of Cardiology and American Heart Association says that uncontrolled hypertension is a minor risk, so we should not postpone the surgery, right? All these things, stage 1 and stage 2 well-controlled hypertensive patient do not have any exaggerated response compared to normal patients. Only the uncontrolled hypertensive have an exaggerated response that we have to take care of. So we have talked so many things. Let us summarize whatever we have talked. So the consensus among the guideline, what is the consensus? Consensus is that elective surgery need not be delayed if diastolic blood pressure is less than 110 mm of Hg and systolic blood pressure is less than 180 mm of Hg, right? So if it is below this, the surgery need not be delayed. If the blood pressure is consistently high, if it is consistently high above 180 by 110 mm of Hg, then we need to, let's say, delay the elective surgery for a short time period and evaluate the patient. Then there can be consideration for delaying elective surgery, right? Now, one very important thing is that we delay the surgery and immediately take the patient after prescribing some new medications to decrease the blood pressure and making the blood pressure within the defined range is not what is recommended. This has shown to cause lot of ill effects. Rather, chronic management of blood pressure is what is required.